Hey, so welcome back. We're going to start the movement disorder session. And the first presentation is an update on Parkinson's disease. So our first speaker, Dr. Mish'al Abu Milh. Dr. Mish'al is a consultant neurologist, and he is the chair of the neurology department at Al Adan Hospital. He's the program director of Kuwaiti Neurology Program. He got his degree from UPC, and he has a fellowship in movement disorder and neuro-ophthalmology. And he's the vice president for the Middle East for with the Parkinson Disease Society. Without further ado, so I'll leave the floor for Dr. Mish'al to shed the light on the update in the management of Parkinson's disease.
So good morning, colleagues. Good morning, everybody. Thank you very much, Dr. Johnson, for this introduction. So my talk is very long. We'll try to make it short and to the point. We'll try our best to do that. So we'll talk about today the updates in Parkinson's disease management, and with the focus on the advanced stage. So I have nothing to disclose. This is the learning objectives to define the advanced PD, a brief overview on the medical management, the fluctuations, and the overview on the medications, the device-aided therapies, and if you touch on the what's going on with the pipeline with the medications. So talking about Parkinson's disease, you know, Parkinson's disease actually it's not a disease, or it's a multi-systemic disease actually. So you need to be aware what are the prodromal symptoms and signs of PD, and actually it starts like 10 years, 20 years, you can name it, prior to the motor symptoms. We have the hyposmia, the REM sleep behavior, constipation, etc. Then we have this 5 years period, just the honeymoon, and then the patient will develop, you know, into the complications. Let's say within the first, let's say 4 to 5 years, the honeymoon period, the patient is fine. The response to the medications is perfect well, but few patients actually in the first, let's say not 4 years, they start to develop these fluctuations. So it's not like a textbook or like 1 + 1 = 2. So there is some variations according to the patient's categories. So after 5 years, the patient will develop more complications, dyskinesias, and resistant symptoms. So there is now a very, you know, fuss about what's the definition of advanced Parkinson's disease. According to the observed study built by Fasano, that with the Delphi criteria, it shows that there is, like, you know, ongoing fluctuations, the burden, the motor, non-motor, the axial symptoms. So advanced PD is a stage of disease in which there's at least one of the following: sufficient disability which interferes with the ADLs, despite of the levodopa therapy, severe axial symptoms not responsive to levodopa, or responsive, depends on the situation, and the presence of the non-motor symptoms. We need to put a shed light on the non-motor fluctuations, especially as we know, the non-motor symptoms are there the pre and during the stage of Parkinson's disease, but there's also the fluctuations, especially the neuropsychiatric, the sensory symptoms, the urinary, the fatigue, sleep, the gastro. All these symptoms can occur as a wearing off phenomena. So we need to broaden our thoughts on how to manage these patients. As you notice, the most troublesome symptom in advanced PD is the fluctuating response to medications, the mood, the sleep, and as mentioned in this slide. This is an overview of the gold standard treatment of levodopa, carbidopa. It's been there since the 60s, and it's the magic drug for Parkinson's disease. And still now, there's doctors are very afraid to start levodopa, carbidopa for the young or for the elderly, giving them low dose for a long time. So we need to manage those patients in a good way. And as I mentioned, quality of life is our aim. And we have the side of the common therapies in Parkinson's disease, the dopamine agonist, which acts on the postsynaptic. We have the amantadine, the MAO inhibitors, the levodopa, and the COMT inhibitors. So these are the medications that have been used, and everybody knows about them. And these are the available preparation for the carbidopa, levodopa. We have the immediate release, the oral dissolving, the Parcopa or the Madupar, the controlled release, and the Stalevo, the Rytary, and we have the intestinal gel. So levodopa, common misconceptions of patients. So, and this is the wrong ideas. Like if I take levodopa now, I will develop tolerance to it in the future. Wrong. I'm afraid to start levodopa because I will use up the good time. Wrong. I should only take medications when I find it impossible to carry out my life. So do you want to start it when you are crippled? Levodopa will cause faster progression to my Parkinson's disease? No. And levodopa is toxic. It's all misnomers, misconceptions. And actually you will face this in the clinic. A lot of patients actually are educated. They were asked these questions. So this is the current standards of treatment, from the early to the mid to the advanced, and this is how it goes. Now it's there's no school. Everybody has their choice on how to start the medications, but as a movement also specialist, we have a special way when we approach a patient with Parkinson's disease, whether in the early, mid, or advanced. As I mentioned, the honeymoon period is the best period. The patient will love you. They're responding very well, and there's no complications. And 50% of patients within the 5 years of levodopa, they can develop the fluctuations, and 100% actually they will develop the levodopa carbidopa complications in 10 years. So you need to know when you approach patient Parkinson's disease, every time you see a patient, you need to ask about the symptoms of the fluctuations as a wearing off phenomena, or there is a delayed on, or there are dose failures, random on off. So these are very important. If you don't ask these questions in your clinic, you're not doing a good job. So these are very important. And most of the patients are not aware unless you go and bring this up. So the risk factors of motor fluctuations, again, young age, female, inconsistent time intervals between doses. We see a lot of patients actually taking medications like every 4 hours, 3 hours, 2 hours. This is wrong. You need to be fixed. When I say 4 hours, 4 hours, 6 hours, 6 hours, it's very important, especially in the striatals pharmacokinetic of levodopa in the brain. Again, food protein ingestion with doses, not only protein, even high calorie, even sometimes high carbs. And don't forget, even iron salt, ferrous sulfate can interfere with the levodopa carbidopa absorption. Disease and the antacids. So you need to ask about all these questions. Disease progression, chronic and high levodopa use, gastroparesis, all these are fit in the, will help in the inducing the complications of levodopa carbidopa. So when you ask about wearing off, we need to ask about the motor symptoms and non-motor symptoms. You can have bradykinesia, rigidity, tremor, and you have the non-motor. You need to ask about the non-motor. Yeah, anxiety, depression. So anxiety, depression, not only as a pre-motor, it can happen also as a wearing off non-motor fluctuation. So, and the management is totally different. Drenching sweats, abdominal cramping, numbness, dyspnea. I have one patient last week came to me with severe sweating and shortness of breath. Once the medication was adjusted, she was totally cured. So it's very important to ask about these symptoms. So what are the questions here? So does your PD medication last from dose to dose? What happens when your medication wears off? Does your dose wear off before the next dose kicks in? What is your PD status when you first awaken in the morning? How long does it take your first PD medication for symptoms to improve? What is your PD status if you wake up overnight, such as going to the bathroom? So all these are very important questions you need to ask the patients. And this is just a hint of what's going on with the fluctuations. You know, you have the diphasic dyskinesia. That's like, for example, when you take the medication, the patient will usually, the levodopa carbidopa will act within 20-30 minutes, but usually it takes long. So as the levodopa rises, the patient will have dyskinesias. And usually the diphasic dyskinesia usually are lower limb, especially in the legs. And it sometimes can occur as a ballistic movements. And some patients actually are diagnosed as a functional with those with the diphasic dyskinesias. And we have the on-peak cortical dyskinesias, and they have fluctuations. So this is just a glimpse of the pathomechanism or the pathophysiology of the why we're having the complications. So it's from the PD itself and from the medications, pharmacokinetics. So you have the microcycle damage that will reduce the synthesis of and storage of dopamine release, loss of buffering capacity, plus there is pulsatile stimulation. And this is the reason that we need to implement the CDS, which is the continuous dopaminergic stimulation, to avoid the complications. Don't forget the peripheral mechanism is very important. The gastroparesis and gastric emptying, that will again will give a touch to the levodopa-induced motor complications as a peripheral mechanism. Again, dysphagia, delayed gastric emptying, the small intestinal bowel bacterial overgrowth, H. pylori. I have a patient actually with severe gastric ulcer, H. pylori positive. He was not absorbing his medications very well. Once that treated, he improved remarkably. So you need to ask about GI symptoms. So all these will lead to the levodopa-carbidopa complications. So we have central mechanisms and we have peripheral mechanisms. It's not only central. So we need to broaden our way to approach patients with Parkinson's disease. Now, as you notice, initially in the early phase, the window is wide. You can change the medications. You're happy. The patient is happy. But as the disease progresses, that window gets narrow, narrow, narrow. The patient will be on, off. He's being on with dyskinesias, off with wearing off. So you need to manage those patients very well with the right medications. And as you know, the pharmacokinetics of oral levodopa-carbidopa, the immediate release, it has a lot of variability. As you can see, the patient within 30 minutes it will act, then it will drop down. Usually in the early, that will not be evident because the striatal damage is not that evident. The neurons are less, but the patients are still going on. That's why we give every 8 hours, every 6 hours. But as the time goes by, this, as I mentioned, the loss of buffering capacity, the synthesis, the storage, then actually it can mimic its pharmacokinetics, and then people will have the complications. And levodopa-carbidopa CR, Stalevo, starting those medications early, I don't recommend them. It has, especially the Cinemis CR, it has a low oral bioavailability. It takes 2 hours to act and lasts 4 hours. PD patients want a kick. Giving CR, it will actually, with this low oral availability, the gastric emptying, it will delay. You can use it at nighttime, in the morning, but putting the patient on a continued release CR throughout the day is very bad, especially in the advanced stage. There is a response, but it will not that benefit. So the goal in the management of motor fluctuation is to provide continuous stimulation, increase the on time with unacceptable side effect, and CDS is the continuous dopaminergic stimulation, is the perfect solution to solve the motor and response fluctuations. And before attempting the strategy, the patient should be optimized medically first. Improving the quality of life is the main aim, and the strategy to solve these issues, as you know, all of you, adding the levodopa controlled release, the extended formulation, dopamine agonists, COMT inhibitors, MAO inhibitors. But even with those medications, even when you start the levodopa-carbidopa intestinal gel, apomorphine pump, are we reaching the complete CDS? Still not. So early management of L-dopa complications is optimizing the levodopa and shortening the dosing intervals. Like a patient's taken every 8 hours, you go to every 6 hours, and then every 4 hours. I have a few patients every 1 hour also. So you need to have a background how to manage those patients. Patients who, let's say, is taking a controlled release tablet, he's out of immediate release. What to do? You need to know how to troubleshoot. Break the CR tablet, it will change from controlled release to immediate release. Patient taking the tablet, doctor, I'm taking the tablet. After 30 minutes, I'm not on. It takes 1 hour. So what can do? Just chew the tablet, drink a carbonated water, and that will actually improve the delayed on the dose failure. Sometimes you can't use the apomorphine penjet. So this is the way you can manage those patients if you're in a clinic or you're on a rush. And as mentioned about protein meals are very important. You need to ask the patient at least to take levodopa-carbidopa 30 minutes to 1 hour before meals or 2 hours after meals to prevent the fluctuations. Now, the medication can be used, as I mentioned, is the strategies is to shorten the intervals. You add the CR, the levodopa-carbidopa into capone, and we had the new one on the black. It's not new, it's been there for years now. It's called the Rytary, and there's another new one coming up now. And it's been shown that it will decrease the off time, increase the on time of 1 hour. But again, it has a complicated regimen. I'm not a fan of Rytary. I have a lot of patients actually not happy with it, which I changed them to the normal levodopa-carbidopa. It's a good medication. And then, so other strategies here is adding into capone. Or a MAO inhibitor. Safinamide, again, is the MAO-B inhibitor. So all these medications were reduced off time by 1 to 1.5 hours. And the new one is on the block, is called opicapone. We know now entacapone now in Kuwait is not available. The company stopped it. So we have the opicapone, and I hope it will be here soon. It's a cost saving. It's only 1 tablet per day, used at night. It's long acting, and actually it helps. And this is the opicapone according to the BIPARC 1 and 2 studies, and it's been shown actually to reduce off time, increase the on time, with sometimes dyskinesia, but again, the compliance is high, cost effective. 1 tablet at night, it will help for that. Again, as I mentioned, a lot of medication can be used, especially the one on the block here is called, if you look down my slide, is the Norians, the estradiol. It is an adenosine A2 antagonist, same as caffeine. It's a new one. It's being used in Japan. It's FDA approved. It will help the patient to be on the off state and less dyskinesias. Extended release amantadine is being used, and it's been well known that amantadine is a well-known medication, but actually in the past it's not been used very well. A lot of physicians are not using it. They're talking about it's not helpful, but actually it's extremely helpful. And I'm using it even in the early PD patients. It has an NMDA antagonist. It helps with dyskinesias and also in the off time. And the new one on the block is the Gocovri, which is a long-acting use at night, which increases compliance. We have the other one. You have the against apomorphine, zonisamide, which has a MAO-B inhibitor effect. Keppra, I'm not using it. Clozapine is an excellent drug, and it's well used. Cannabis is not much used very more. So these are just a glimpse of how you manage all the motor fluctuations, the big dose dyskinesias, the diaphasic and early morning off periods, dysphonia. And these are the medications used from MAO-B inhibitors, entacapone, and the dopamine agonists. Again, safinamide is another one used, excellent. It has a dual action on the sodium and calcium, and it reduces the neural glutamate, and actually it's been shown to increase the on time and decrease the off time. And I mentioned about the estradiol. Ortiquetine Nupropash can be used against the dopamine agonist. It helps again the motor fluctuations, increase the compliance. We have also the on-demand therapies. It's very important for those patients who have unpredictable off states. We have the sub-Q apomorphine pump, the sublingual apomorphine, and we have the Embrigia, their oral levodopa. All of them are FDA approved, and they're used on on-demand therapies. Sub-Q apomorphine has been approved a long time ago. It's very important. It's a levodopa equivalent. It's not morphine. It's very nice. It's very effective for patients with PD who has off symptoms, especially the predictive ones. And it's comparable to L-dopa, and stronger actually, 10 times stronger than the D1 receptors. It has serotonin and alpha-adrenergic receptors also. And these are the pen. And it has actual 5 to 20 minutes action and long lasting till 40, 60 minutes. And actually it shows very fast acting compared to the dispersible levodopa carbidopa. And again, it's very important. It helps a lot in patients who are having off periods. We usually use actually 5 times per day. It helps fatigue, falling asleep, restless legs, urinary issues, and it has actually thermolytic effect. Okay, and again here we have the apomorphine, the sublingual, which is on the block, FDA approved. Within 15-30 minutes, it shows an effect. But the pen, it shows an effect earlier, 5 minutes early on. And this is the MAO-B approved, FDA approved, sublingual apomorphine. And again, this study shows very remarkable improvement within 30 minutes. Okay, and again, this is the Embrigia also, FDA approved, inhaled levodopa carbidopa, 2 capsules. Maximum use is 5 times per day. We need to be aware that the on-demand therapies are very good, but again, we don't want to use more than 5 times per day. It can cause fluctuations and pulsar stimulation. Okay, so when should the patient be considered for device-aided therapy? We have the 5-2-1 rule. When you have more than 5 tablets per day, 2 more off symptoms, and more than 1 dyskinesias, these patients are eligible for advanced therapies. So we have this is the way when the medication is not working very well, the quality of life is not improving, then we are in a good time to go ahead for the advanced therapies. We have the levodopa carbidopa intestinal gel, the DBS, deep brain stimulation, and the sub-Q apomorphine. I will touch a little bit on the HIFU. This is the MRI guided focused ultrasound. DBS, there's a selection criteria for it. Patients should be idiopathic PD, absence of red flag, less of axial symptoms, especially the on ones, younger age. So in the neurostim PD test, the early motor fluctuations show that STN-DBS shows barely improvement in those patients, especially in the early stage of fluctuations. And it has been shown that DBS also has improved the non-motor phenomena, especially for those patients when the oral medication load is reduced after that. And again, for the HIFU has been FDA approved for essential tremor, and also is FDA approved for PD tremor only, not for the other symptoms of Parkinson's disease. Although there's one study done in 2020 with the subthalamotomy, it's been shown that it improved bradykinesia rigidity, but again, the study is small and we need more large trial for that. Apomorphine pump with the Toledo study, again, showed that patients has increased off time and on time, and very good treatment for PD patient advanced. And this is the adverse effects, the somnolence, cannot use like edema of the apomorphine pump. Okay, and this is again the absolute contraindication of pregnancy, hemolytic anemia, fluid psychosis. And this is the current practice when to use the pen of apomorphine pen or pump. You can use the pen up to 5 times per day, but if the patient is fluctuating more than 5 times per day, you can shift from the pen to the pump just to provide that smooth, smoothing out the fluctuations. Then we have the levodopa-carbidopa intestinal gel. It's been shown it's remarkable and can be used in monotherapy. Even apomorphine pump can be used as a monotherapy. But but usually patient will fluctuate. That's why we need to put patients on the oral medication, but reduce the dose. And patients actually with levodopa-carbidopa intestinal gel, you can put them on the monotherapy. And the study has been shown. The 12-month follow-up, according to the Olano study, shows a decrease of time, increase on time of 4 hours. And the complications, again, is from the abdominal pain, peritonitis, but again, that's less than 1% actually. And it's been shown actually in those patients, dyskinesia is less, especially those with high basic dyskinesias. And actually within 2 weeks, we see actually in those patients with the LCIG that the dyskinesia improved according to the Discover study, even the motor fluctuations decreased within 2 weeks. But usually for those with patients with LCIG patients, the fluctuation and dyskinesia, it takes 3 to 6 months to improve, but sometimes we see it early, especially dyskinesias. Again, the tremor, pharmacoresistant tremor, it's not only DBS, LCIG actually improve pharmacoresistant tremor. Okay, I will just show up the light that again, neuromotor symptoms improve with LCIG. The impulse control disorder improve. Again, as I mentioned here, the sleep, GI symptoms, mood, apathy will improve according to the dual globe second interim analysis. And regarding to the Europe multicenter comparative study between apomorphine and levodopa, both of them are excellent, but more levodopa on the UPDRS for the dyskinesias. The autonomic symptoms, the quality of life, the sleep are more efficient, benefit of both. But again, the mood and apathy, the APO shows more effect more than levodopa-carbidopa intestinal gel. And again, that's again a summary between the DBS, the duodopa and apomorphine. All of them will improve the normal symptoms, but the LCIG gives more benefit. Again, this is one observational study has been shown that the LCIG has a comparable effect with STN-DBS. Okay, so, but that needs actually more studies. And according to the Cosmos studies, actual patient will be on levodopa intestinal gel monotherapy for years, table on that. And so, and then to supplement the summary, we have the pipeline, we have the neuroderm, we have the levodopa-carbidopa patch pump, and we have the sub-Q pump still ongoing. It's a good medication, will smooth out the fluctuation. We have the one with AbbVie still in the studies as the phoscarbidopa-levodopa, it's a sub-Q, same as apomorphine pump, but that's levodopa. And there's one also called the LCAIG, which is levodopa-carbidopa intercomponent intestinal gel. It's only in Sweden, still ongoing. It's the same as levodopa, but the good thing about it is that it's a smaller pump, and actually it will help the nighttime shift for the patients. But again, you can use it. You can use levodopa-carbidopa 24 hours. So from my point of view, I don't think that will be more helpful. So this is in summary, in the pipeline was available. Just one new one on the block is coming out. It's called the DOPA fuse. It's a retainer which will we had the small drips of levodopa carbidopa at the back of the tongue. It's good for fluctuation, but still in the phase 2 trial. And this is a summary about the medications available. It's in the pipeline. So, so who are the good candidates for device-aided therapy? So patients who are levodopa responsive, resistant, all of them are good. Patient with resistant tremor, DBS is the perfect one. But let me say this: even patients with resistant tremor on levodopa with the LCIG, duodopa, will improve remarkably. And I've seen this in my own practice, even refractory dyskinesias. Okay, so again, this is again a summary of the candidates who are fit for, let's say patients elderly, more than 70 years old. He has cognitive, some hallucinations, and he has some ICD, So the best thing for those patients is levodopa carbidopa intestinal gel. So you need to choose, according to the characteristics of the patient, which modality is better for him. Okay. And again, so which treatment for which patients is identical indication for all three. Persistent motor fluctuation, despite optimized, you optimize the patient at your best. And DBS is more for the patient with refractory tremor dyskinesia. But let me say that even levodopa intestinal gel and apomorphine pump will help in those patients. DBS is the only one which has restrictions, especially for age, cognition, impaired postural freezing, which was severe depression. Both infusion therapies has no age limit. So when you see a patient in the clinic, I'm ending now here, my talk, is that a patient should be aware about the treatment. I'm seeing a lot of patients in my clinic. Doctor, I never heard about duodopa. I never heard about apomorphine pumps, all DBS. That's wrong. We need to remove that bias. We need to look at the patient characteristics, and you should put all the medication on the table, explain for each patient what's the pros and cons of each medication. That you will gain the trust of the patient. And this is the summary which I mentioned. You need to optimize the patient medically. If that failed, you go on for the advanced therapies. And the conclusion is PD is a complex multi-system disease and needs a deep dive approach. Best quality of life in PD is as peak should be achieved. Medical optimization should be reached before considering device therapies. Once early motor complications appear, must be taken seriously and to manage early. Time is brain. Once the patient reaches the 5-2-1 rule, please refer to the movement disorder specialist so we can take over. And the palliative approach with device-aided therapy, especially with LCIG, can be achieved in selected patients actually. Thank you very much.
Thank you very much, Dr. Mishal. This is an excellent review for the update, also in the management of